different kind of presentation, and it's on medicinal plant activities, and we are uh, using the curcuma we have used for chemo prevention, and the Tinospora we are going to try to use to reduce side effects of chemotherapy. We are a multi-system, multidisciplinary team, and soon we will be known as the Kasturba Integrative Health Sciences Medical Research Foundation. These are the general common steps in carcinogenesis. All of you are aware, so I'm not going to dwell on these. But there is a possibility of reversal in many stages. And once these 5 major mutations occur, it becomes a little more difficult, it becomes invasive. And personally, I'm very much convinced about the role of inflammation. So, particularly because I'm a gynecologist, I've been working on prevention of cervical cancer. Apart from HPV, which is not easy to treat, of course, uh, other infections also play a role in changing the microenvironment and promoting carcinogenesis. Now, as far as Ayurvedic concepts are there, I won't go too much into details, but even I was not aware until until I joined. After retiring from Indian Council of Medical Research, I joined this team and learned something about Ayurveda. And here this shlok, ancient shlok, Vrittam sthiram mandarujam mahantamanantu moolam chiravruddhya pakam kurvanti mahamso shreyam atyagadam tad arbudam shastravido vadanti, meaning arbud is the name given to solid cancers, and it is a painless, causeless, round, immobile swelling, very well described, deep rooted and destroys the tissues, etc., etc. And there are concepts of recurrence also, recurrence and metastasis. And the medicinal plants have been used by traditional physicians for centuries. These have been, some of the major plants have been analyzed here, and our former director shortlisted them, and we find that Tinospora and Curcuma longa both are listed. So first, I have been mostly involved with the Curcuma longa studies, and this is curcumin and the turmeron, which are the most frequently investigated. We know, of course, that there are more than 300 bioactives actually when we use an extract and not the pure compound. So this is the list of the clinical studies, because although there are literally thousands of studies on curcumin, there are very few clinical studies, and particularly on extracts. So this is the list of studies. The first 2 were ongoing when I joined this team, and here oral submucous fibrosis and antioxidant activity was being studied. When I joined, I participated in all these studies subsequently, and this major group is with the related to cervical cancer. This was studies in healthy volunteers. So the first study actually showed at our center that symptoms as well as signs of submucous fibrosis can be reversed by oral turmeric oil capsules. And because turmeric has got systemic effects also. And I myself, although I'm a clinician, I'm interested in lab studies. So I had seen this reduction in number of micronuclei before treatment and after treatment. Another student had completed 3 antioxidant enzymes, which she showed serum levels had increased. So this was a study in which I was actively involved, and we got it done at the clinical pharmacology ward. And one can see that the organ function tests before and after treatment at 0, 4, and 12 weeks, and they were well within the normal limits. We even did the coagulation test over here. One patient, these were not patients actually, these were healthy volunteers. but one volunteer got an allergic reaction, and it is known that even turmeric can cause allergy sometimes. Just to give you a little bit of my previous background, I am a gynecologist with PhD in clinical pharmacokinetics and dynamics of oral contraceptives and drug interactions. But I am also an very much interested in gynecologic cytology. My thesis, MD thesis, was on cytology, and we learned to uh, detect several infections as well as cervical precancer. This is adenocarcinoma, this is squamous carcinoma, and precancer. And we thought, why not try the turmeric oil in cervical precancer? And we got a special, now that is the uniqueness of our center, that our extracts are very well standardized according to all the international as well as national standards. And we conduct a healthy volunteer study first. Even this supercritical extract of turmeric oil was specially prepared for this, and oral turmeric oil capsules were given. And it was, of course, approved by the ethics committee. 21 women with LSIL agreed to participate in all these studies because we were insisting on so many vaginal examinations as well as blood examinations before and after. And out of the 19 cases, 16 had regression. None progressed during 12 weeks of treatment, and 3 had arrest. One discontinued due to local vaginal symptoms. The cytology improved as well as the colposcopy, and there were no general systemic adverse effects, as well as all the organ function tests, blood as well as urine were normal. Now, the funding stopped, but we continued to study. And the sera of these women, we had taken the informed consent already. And then we studied some women with inflammation also. And the serum, this was actually a very good finding that encouraged us to study further. That the serum interleukin levels also were high in LSIL, low grade squamous intraepithelial lesions, that is LSIL. And uh, after treatment, they decreased. So that was good for us to know. And although we didn't have any support for social workers or follow up, we, on our own, we tried to follow up, and 18 cases from the study group and 10 controls. As I said, the integrative aspect lies in first the treatment of the inflammation. So we always give NACO or internationally approved uh, protocol single doses for leukorrhea, uh, a white discharge, and uncomplicated one, both to the woman as well as the couple, as well as the husband. And we ask them to follow 1 week of abstinence so that reinfections are not there. And then we treat with the turmeric oil. So in the study group treated with both antimicrobials as well as turmeric oil, there was no recurrence. In those treated with only antimicrobials, half the cases had LSIL report. In the other half, they had responded to the treatment maybe, or spontaneous, we have no idea. So the beneficial effect we thought was not transient but was persistent. And incidentally, a Cochrane analysis in 2013 shows that even after surgical ablation of LSIL and other lesions, the recurrence rate is 3 to 7% within 3 years. And our data was also for 3 years. So this really encouraged us. And one case of ascus, actually, she, after informed consent, she had a second course and it became normal. So showing that repeat treatment is possible after some interval if there is a recurrence also, but we have not pursued it further. One case incidentally followed up for a long time, we'll be showing it last. Now, after that, we had a series, actually my research fellow decided to do her PhD She is a molecular biologist, and she studied both Tinospora as well as Curcuma longa, and she showed uh, anti-migratory and anti-angiogenic. Here, VIGF was used as the stimulant, and other activities also which showed anti-cancer activity, and she showed that the mixture was better. There were also at the same time two international publications which showed that termeron and curcumin given together are better in vitro studies, not clinical studies. So in the next study, we decided to take a holistic extract which had an equal proportion of uh, turmeric extract, turmeric polysaccharides, curcumin, and turmeric oil. And out of these 20 cases, none progressed, 18 regressed, and 2 persisted. 4 continued for local irritation. Here we feel that the curcumin that we had used is was a newer formulation, lipid solid variety, which was more bioabsorbable, and that's why the side effect was there. But even these, if even if they had taken it only for 4 weeks, they showed the regression. Now, the nucleocytoplasmic ratio, as in the previous study, because we did micrometry of all these abnormal cases before and after treatment, and the interleukin 6 also decreased. Colposcopy also regressed, and the effect was persistent at 6 months in 14 out of 20 cases. So these are the last 2 studies. These are small studies. Uh, the this previous data, incidentally, was presented at the American Society in 2019, and then it was published. So I have been, frankly, I feel nobody should have cancer if it can be prevented. And that's why I was very much impressed by worldwide data, global analysis on risk factors for cancers. And they had included cervical cancer. And there is another paper only on cervical cancer, also risk factors. And they have postulated that up to 45% of cancers are preventable. So we thought we had not really looked into these preventable risk factors in greater details. So at least these case record forms of these 20 cases were available to us. So we went through them and indeed found that they had risk factors. We had detected them. It's not that we had not detected, but we had not emphasized uh, so as to advise them that these factors, if you limit, if you cause their regression, your cervical cancer development chances are also likely to reduce. So I believe that at least the screen positive cases uh, should be advised regarding the preventable risk factors, and the progression can be reduced. This last study, as I said, one case came for long-term follow-up after integrated treatment with the first, from the first study, that is turmeric oil capsules. First the antimicrobial kit, then persistent LSIL and CIN1 in colposcopy, and followed by oral turmeric oil for 12 weeks. And then after 12 weeks of treatment, there was no LSIL, CIN, nothing at 6 months also. And this patient, incidentally, had we analyzed her preventable risk factors. She had few only, very good lifestyle. And after 11 years, she underwent pan-hysterectomy for a growing ovarian cyst. And there were no abnormal cells either in the cervix or in the uterus, but there was a dermoid cyst, benign one, luckily. So this has been presented also and submitted for publication. Now, we didn't have the opportunity to study oral submucous fibrosis later, although we had studied it earlier. But there has been meta-analysis. Some other centers and colleges have used some other turmeric extracts as well as some other medicinal plants also. But curcumin data has been analyzed in a meta-analysis and clearly shows favorable effect, uh, concluding that there is some role of curcumin in reversing oral submucous fibrosis and preventing carcinogenesis. Now coming to Tinospora cordifolia, that is guduchi as it's called. Like turmeric, we know it has also got many active ingredients, and we usually have a look at all these structures and their properties. And literally, there are thousands of experimental studies, but few with respect to cancer. Basically, our interest started because at KEM Hospital Pharmacology Department, that is not at our center, but another center, they showed in experimental studies as well as in one clinical study, I'll show it to you later, that the quality of life improved. And there is a GM-CSF like activity with uh, Tinospora cordifolia, but not many studies with clinical experience on cancer. But there are other healthy volunteer studies. But this study was following the KEM study, and they studied at Tata Memorial Hospital, Cancer Hospital, and they found there was decreased leukopenia, side effects, and continuation rates were more. These are other studies in some other diseases. And this is Dr. Raut, my co-author and my Ayurvedic colleague. And they also showed in healthy volunteers. This was another study, recent one, which showed they had used Tinospora cordifolia or glycyrrhiza glabra, and they found versus placebo, or no control cases. And there was decreased vomiting and leukopenia. Our former director had shown in an advanced ovarian cancer survival up to 7 years with the use of Tinospora. Of course, this was add-on therapy. So during COVID pandemic, actually, Tinospora aqueous extract was used extensively both by the Ayurvedic Council, and nationwide studies were conducted, and the safety was more or less can be taken for granted. And a placebo-controlled study we designed under the our center was granted the ICMR Product Development Center. So one of the products we are participating in clinical trial, but this was not funded by them, but this is funded by some other source. And because the project itself has been winded up. So the placebo-controlled trial, randomized study we have undertaken with in patients with advanced, this is not for prevention, but this is for reducing side effects, events profile, and continuation rates in patients receiving docetaxel-based chemotherapy. This we are doing in collaboration with Tata Memorial Center and Tata Memorial Hospital. Now, no work can be done without great teamwork. This is Dr. Ashok Vaidya, our former, unfortunately, we lost him last year. But these are my colleagues. This is Ayurvedic MD. This is the PhD in molecular sciences. This is Dr. Raut. And these are my colleagues at Sion Ayurveda Hospital. This hospital actually was not doing any routine cervical cancer screening till we started some research projects first with the treatment of infections. And for the last 25 years, a regular cancer screening is going on over there. And these are the gynecological colleagues who are participating in these studies. And this is the Miss Neeraja who has participated in the recent most study. Thank you all very much.
And I'm honored. No, go back, please. And I'm honored to take part in this one event. From my last experience last year, I'm very grateful that I can meet so many interesting people and share my work as well with you. So could you just go back, please, to the first, this one? Thank you. Not the previous one. Okay, so this study is about rectal cancer and actually the view from patient side. At the moment, I'm teaching at the University of West Attica as assistant professor in perioperative nursing, but this study was conducted between University of Crete and King's College Hospital in UK. So next one, please. Briefly saying about transanal endoscopic microsurgery, that this one is microsurgery. It's a minimal invasive alternative to the total mesorectal excision. Total mesorectal excision at the moment is the gold standard for colorectal cancer treatment. And still, the colorectal cancer is the third most prevalent cancer globally and second leading cause of cancer-related mortality around the world. Next, please. The advantages of this one surgery is that you do have preservation of sphincter and rectal function. Patients do faster recovery and have a shorter hospital stay. They have significantly lower morbidity and mortality compared to total mesorectal excision. And TEMS can apply only in early rectal cancers. These benefits are particularly important, of course, for older or frail patients because of the minimal surgical trauma and preserving organ functions. And those two can lead to the better quality of life. Next, please. Selection of patients is very narrow because if you're looking at Haggett classifications, it depends on the level of cancer invasion along the polyp stalk. And Kikuchi classification says that the recurrence risk is very high and actually quite fast. If you see the submucosal invasion in SM3, it's already 23% of recurrence instead of the first one, which is just 3%. And it's understandable that the selection should be very strict for this kind of operation. Next, please. As for patient experience along with clinical effectiveness and safety forms one of the core pillars in health care quality. And it has the patient experience itself has two aspects. One is the relational aspect and the other is the functional aspect. Relational aspect includes provision of clear information, emotional support, personalized communication, respect, courtesy, involvement of the patient and their family in care decision. And of course, we have emphasis on taking in account the patient's preferences and values. As for functional aspects, those relate to basic expectations about how care is delivered, such as attention to the physical needs, timeliness of care, clean and safe environment, effective coordination among professionals, and so on, and continuity, of course. And there are numerous studies that support that there is positive association between quality of life and patient experience. So next, please. So in our study, we actually see the interplay between experience and outcomes from TEMS surgery. And this study, as I said again before, conducted at King's College Hospital, Department of Colorectal Surgery. The patients were from there. And this department is actually a reference center for TEMS surgery. And of course, ethical approval was obtained by NHS Law and Research Ethics Committee. And next, please. We studied 34 patients. That was the final cohort with stage rectal cancer stage T1, T2, no nodes involved, no metastasis, and they had undergone TEMS at least 3 years to we started this study. And tools that we've used to assess quality of life, it was the generic tool, which is short form of SF12, and of course specific tools for this kind of investigation, which was the Wexner score for bowel function and the sexual function questionnaire. And of course, because we have organs in the lower pelvis involved in this surgery. And as for patient experiences, we reevaluated those with a specially designed questionnaire by the researcher teams. And could you please move on? No, that's the previous one. Next one. This one. Okay, so the results were that the cohort of patients had mean follow-up nearly 7 years, and the mean of age was 75.6 years. Patients rated their TEMS experience highly, with a mean score of 7.9 on a scale of 0 to 10, and that was the most positive experience they had. As for bowel function, postoperatively bowel disruption was rated acceptable or relieving by 66.7% of patients, and experience ratings were positively associated with this one bowel function post-TEMS. And also it was correlated positively with preoperative information patient received and the mental health quality of life. As for pain, the postoperative pain was minimal, median score of 1, and it was correlated. Lower postoperative pain was reported by patients who received or had greater family support. As for information, go back. Sorry. Okay, never mind. So, physical quality of life was lower than the general population mean, in particular among males, but mental quality of life was comparable in both sexes and for the whole cohort. About continence, good or perfect continence was reported by 82% of patients with a mean score of 3.97. And just to remind you what is continent levels in this one tool, perfect is 0, good is 1 to 7, and progressively we are going to the severe incontinence, which is the top 20. So 3.97 is a very good level for this kind of patients. As for sexual function scores did not differ between gender, but declined by age. And mental quality of life was associated with sexual problems. There were fewer if the mental quality of life was better. And they had greater satisfaction. Overall, 86% of patients were satisfied with TEMS, and that was linked to the lower bowel function, to the better bowel function, or said differently, to the lower Wexner scores. Next, please. So the experience was assessed with a custom-made questionnaire. What had this one questionnaire? It had patient experience rated on 0 to 10 scale, about information. If information was provided in written, it was clear. If information had covered all aspects of the treatment alternatives. And another one was if experience was according to information provided beforehand, which was a multiple multifactorial approach to ask about experience before, after, in connection with information provided before. And if a patient had discussion with nurse specialist, which is an compulsory member of the colorectal team, and what they've been, what they had as a family support. If they had a good one, and they could discuss alternative choices of the therapy with family members. Next, please. So as I said before, experience was rated 7.9, and this one was correlated positively with family support. So those who had more family support had better experience, and those who had less disrupted or acceptable levels of bowel function postoperatively, they expressed better experience in TEMS. And those who had, this one is current mental quality of health, if the score were high, then experience was high as well. And the next, please. So there was one question, which was your experience after TEMS in accordance with what was told to you beforehand? And that is important for the patient, that as soon as you have the information and you understand that it the same exactly what you've been thinking before and you felt and lived after the surgery as you've been presented before that. That, of course, involves both the technical aspects and the relational aspects. And patients, 66% said that it was as I have been told. And this one, those patients positively associated, the patients who told that had better family support, and they reported better satisfaction. So that's a very important one question if you want to ask in reality how you feel afterwards, as soon as you've been presented what you are going to have as a therapy. And in conclusion, the next one. Next one, please. So we can say that TEMS is associated with favorable long-term quality of life and high patient satisfaction. It's, of course, demonstrating the value as a minimally invasive treatment option for patients with rectal cancer, early rectal cancer. Thank you very much for your attention.
Department of Radiation Oncology, Sher Kashmir Institute of Medical Sciences, Srinagar, India. Today, I will be presenting my paper titled Oral Glutamine, Is There a Role in the Amelioration of Radiation-Induced Mucositis? This is a prospective case control study at a tertiary care center in North India. Next slide, please. As per Globocane 2022, head and neck cancers accounting for 4.45% of all cancers globally. It is the 7th most common cancer worldwide. The highest incidence rates has been seen in Southeast Asia, particularly in India. As far as the management of head and neck cancer is concerned, radiotherapy is one of the cornerstones, but leads to inevitable toxicities in the form of mucositis, xerostomia, dysphagia, loss of taste, and osteoradionecrosis. Oral mucositis is the most frequently Oral mucositis is the most frequently occurring side effects of head and neck cancer radiation. Around 80% of the patients with head and neck cancers will develop oral mucositis during radiotherapy. Next slide, please. Next slide. Next slide. Around 80% of the patients with head and neck cancer will develop oral mucositis during radiotherapy. As per the radiation therapy oncology group studies, conventional fractionation regimens lead to grade 3 and grade 4 oral mucositis in about 25% of the patients, while as accelerated regimens will increase the same to 50%. And to see the pathogenesis of oral mucositis, it includes the direct cell damage to the DNA, followed by tissue damage to the submucosa and basal epithelium, leading to inflammation and ulceration and healing as the final stage. Glutamine is one of the abundant amino acids which is found in the human body, including the GI tract and the oral cavity. Next slide, please. Glutamine characteristically exhibits beneficial immune-modulating, anti-inflammatory, and antioxidant effects. It helps in preservation of the mucosal structure after damage by radiotherapy. And several randomized controlled trials have evaluated the efficacy of oral glutamine in the prevention of radiation-induced oral mucositis in patients with head and neck cancers. And they have found that oral glutamine is effective in decreasing the onset and the severity of oral mucositis in head and neck cancers. Next slide, please. So oral administration of glutamine not only provides nutrition to the patients, but also decreases the severity of oral mucositis in patients with head and neck cancers. So we conducted this study to see the efficacy and safety of oral glutamine in head and neck cancer patients undergoing radiotherapy and chemoradiotherapy. Next slide, please. So the materials and methods. The study design was a prospective case control study, and it was conducted in the radiation oncology department at Sher-e-Kashmir Institute of Medical Sciences, Srinagar, India. And we enrolled the patient from January 2021 to August 2022. The primary endpoint was to look for the efficacy and safety of oral glutamine, and secondary endpoint was to see the severity of the oral mucositis using the various criteria. We have used the CTCAE version 5 criteria here. Next slide. We have taken a total of 60 patients, 30 as cases and 30 as control. The calculation method used was G-Power software and with a power of 85%. Next slide. We included patients with histopathological proof of malignancy in the head and neck region who were assigned to receive definitive or adjuvant radiotherapy and chemoradiotherapy with an ECOG performance score of 0 to 1. We have excluded patients who have already received radiotherapy to the head and neck region or in whom the intent of the treatment was palliation only. Next slide. A total of 60 patients with head and neck cancer receiving definitive or adjuvant radiotherapy with or without chemotherapy were randomized by computer-generated random numbers. 30 patients received oral glutamine, each sachet containing 10 grams of glutamine that is dissolved in 500 ml of water 2 hours before radiotherapy, while 30 patients received placebo before RT with the same dose and schedule. Patients were advised to swish their mouth with the glutamine solution first and then swallow it 2 hours before radiotherapy, 5 days per week for 6 to 7 weeks on the days of treatment only. Next slide. Radiotherapy was administered at the rate of 2 grays per fraction, 5 days a week to a total dose of 66 to 70 grays. Patients were assessed weekly for the grading of the oral mucositis. Patients were stratified based on the radiation therapy field, the age of the patient before allocation. And the common terminology criteria for adverse events, version 5, which was published on November 27, 2017, has been used to score the mucositis. The onset, the duration, and the grading of the mucositis were recorded and compared weekly. Next slide. Coming to the results, the baseline characteristics were well balanced between the two groups. In our study, we divide the study arm and the control arm based on the demographic profile, the tumor site, the stage of the disease, the treatment provided, and the radiation fields used. Next slide. So here you can see the mean age in the cases. In the glutamine arm was 59, while as in the control arm it was 55 years. Next slide. In the cases, 90% were males, while as 10% were females. In the control arm, 73% were males, while as 27% were females. Next. In the cases, 57% of the patient had laryngeal cancer, followed by nasopharyngeal cancer in 20% and hypopharyngeal cancer in 20%, while as in the control arm, 50% of the patient had laryngeal cancer, followed by hypopharyngeal cancer in 30% and nasopharyngeal cancer in 20%. Next slide. Majority of the patient in both the cases in the control had T3 and T4 lesions. In the cases, 63% had T3, T4 lesion, while in the control arm, 57% of the patients had T3, T4 lesions. Next slide. In the cases, 50% of the patients received radiotherapy alone, while 50% of the patients received concurrent chemoradiation, while in the control arm, 43% of the patients had received radiotherapy alone, and 57% of the patients had received concurrent chemoradiation. Next slide. So in majority, in both the cases in the control, in majority of the patients, around about 70% and 73% in both the cases in the controls, both cervical and facial fields of radiation have been used. Next slide. In both cases and controls, 77% of the patients has received radiation as definitive treatment. Next slide. So this is the comparison of the number of the patients who developed mucositis in both the arms. So in both the arms, in the cases, 90% and in the controls, 93% of the patients developed mucositis. But here you can see in the cases, grade 3 and grade 4 mucositis are less as compared to the control arm, which was statistically significant. Next. Here is the comparison of the duration of the mucositis between the two arms. So here you can see in the cases, the total duration was 8.94 days, whereas in the control arm, it was 14.54 days, which was also significant. Next. So this is showing the comparison of the time of onset of the mucositis between the two groups. So here you can see again the total time of grade 3 and grade 4 mucositis was higher in the control group, and it was less in the cases. Next. This is showing the development of mucositis in elderly patients above 60 years. Here again in the cases, we have lesser percentage of grade 3 and grade 4 mucositis as compared to the control. Next. This is showing the mucositis in patients receiving concurrent chemoradiation and RT and only radiation. Here in the RT alone, we do not have any grade 4 mucositis, while as in the concurrent chemoradiation group, in the cases, we have lesser number of grade 3 and grade 4 mucositis as compared to the control arm, which was statistically significant. Next. So the cornerstones for treating head and neck cancer continue to be radiotherapy with or without chemotherapy, but following a course of treatment, certain unsettling issues that are primarily brought on by the harmful damage from radiotherapy and chemotherapy on the body tissues. One of these radiotherapy side effects that receive a lot of attention is oral mucositis, which has a high incidence, dose-limiting toxicity, and a negative impact on the patient's quality of life. The current management seems to treat radiation-induced mucositis focus on the use of bioactive compounds like anti-inflammatory, antimicrobials, but the results are inconsistent. Next. As evidenced by published data, glutamine can enhance DNA synthesis by activating the ornithine decarboxylase and also plays an important role in glutathione synthesis, which can decrease the oxidative stress. In this case control study, we evaluated the effectiveness of oral glutamine in delaying and decreasing the grades of oral mucosites, and we found that oral glutamine delays the onset of oral mucosites, decreases the severity of oral mucosites, and decreases the duration of grade 3 and grade 4 mucosites in patients of head and neck cancer receiving radiotherapy or concurrent chemoradiation. Next. The only limitation of our study was a small sample size, because the reason for this is the head and neck cancer, the incidence is very low in our part of the world as compared to other states in India. Next. With this, I concluded that our research demonstrates the effectiveness of glutamine in reducing the incidence, the duration, and the severity of oral mucosites following head and neck cancer radiation therapy or chemoradiotherapy. It is quite heartening to learn that patients with head and neck cancer who are experiencing severe mucosites as a result of the conventional treatment might have their symptoms significantly reduced by using such a practical, safe, and economical option. Thank you very much, and I want to thank all the organizers, all the participants, and I'm very humbled to be part of this conference. Thank you very much.
University in Krakow, Andrzej Frycz-Modrzewski. My subject of the presentation is quality of life, independence and support, and after, before and after surgery with spinal cancer. Spinal tumors are significant clinical and epidemiology problem. It is the subject of my presentation because in Poland for several years the incidence rate among malignant tumors has between 5.5%. With translating into and cancer in a given anatomical area are most common in people over 35 years of age. The incidence is almost 5 times higher in men than in women. Spinal tumors are a significant clinical and epidemiological problem. Next slide, please. Thank you. Satisfactory treatment don't always mean a high quality of life for the patient. Since the interest and inequality of life issues resultant in an emphasis in the treatment process on responsibility for all server of the patient life. Concern began to be expressed not only for prolonging the life of patient in a biological sense. Quality of life in one of the paraments treat patients along with overall survival and disease-free life. It is a very problem in medicine in spinal cancer. Satisfactory treatment review always mean a high quality of life for the patients. Please, next slide. And this subject of my presentation is the study was conducted from March and in department neurochirurgy as the Department of Neurological Rehabilitation in hospital in Kraków after obtaining management, approval from the bioethical committee on clinical trials was objecting prior to the study. The study group included 47 patients who were coded for surgery for spinal cancer. Patients give written informed consent to participation in the study with targeted patients before surgery and after surgery of the patient was the sugar home. Please, next slide. The study was conducted by analogous medical research in the MEDIS program by the diagnostic surgery using the self-administration questions. It is the following standardized result. It is questionnaire eyes, ZMAT scale, and quality of life assessment questionnaires, and Lafton scale ADL. It is the standardized research questionnaires. Please, next slide. Thank you. Calculations were performed using SPF sort 5. The result or questions were presented using describe statistic for questions variables and were presented. The difference in the lower of variables between the pre and post treatment measurement was using the Wilcon test for the potent samples. It is Kruskal-Wallis test were performed to assess the significance of difference between the more groups. Sperman's correction were used to assistant as between question non-parametric method whereby Horan to distribution from a normal distribution. Please, next slide. It is the tape on the statistic and quality of social dormant and before and after surgery. It is the statistic subject of somatic domain and psychological domain and social domain and environmental domain after and before surgery. Please, next slide. It is the result that the assessment of the quality of life of patients before and after surgery for spinal cancer, taking into account for domains in presenter in tablet 2. It is tablet 2. It is the quality on soma domain, psychological domain, and social domain and environment. It is statistically segment differences were for between pre and post treatment. Measurement of quality of life of the psychological domain, and it is P, significantly lower quality for were found after surgery. Please, next slide. It is the in table 4. It is the result, the relationship between quality of life in patients before and after surgery for spinal cancer and the location of the spinal tumor. It is a thoracic section of the spinal tumor presented in tape 2, 4. It is quality of somatic domain and psychological domain and social domain after and before surgery in group patients and environmental domain in group patients, in group in hospital in Krakow. A location of the vertebrate column tumor, it is quality somatic domain after and before surgery. Please, next slide. Please, next slide. Yes, it is the Kruskal-Wallis test result in tape 5. It is the quality of somatic domain and psychological domain and social domain or any formal domain before and after surgery. It is the statistic tape presented in table 5. Please, next slide. Result of the statistic were statistical significant never-errance between tumor grade and treatment quality, domains somatic, psychological, the relation between grant and quality of life before and after surgery, and between tumor grant and the disease accepted scale are presented in table 6. It is the quality graph somatic domain, psychological domain, social, and it is after and before surgery, and total skull is after treatment. Please, next slide. Result and my presentation, the relation between the different they was statistic significant weak position between the air skull after surgery and somatic domain before surgery. The relation between social support and quality of life before and after spinal cancer surgery, there were no statistic significant relation between the variables. Please, next slide. Conclusion. Quality of life after surgery in terms of somatic, psychological, social, and environmental domains depend on the strength of the cancer, quality of life before surgery in terms of somatic, psychological, and domains on the degree of cancer, the degree of accepted of the disease does not on the strategy of spinal cancer, of the quality of life in terms of the statistic domain before treatment is higher, and are the accepted of spinal cancer after surgery is higher. On the other hand, patients whose quality of life in lower between surgery, difficult in moving or complaining of pain, also have lower accepted of time disease after surgery, with manifested as a negative emotion relating to disease. Please, next slide. My summary of the presentation in the global assessment of health quality of life, in addition to taking into upon the symptoms of the disease and advance treatment, the patients think toward himself, his own disease, and the way he cope with the disease all along. Future reserve should, with quality of life in a holistic conscience, in holistic treatment in patients with the spinal cancer. Please, next slide. Thank you for your attention. Thank you.
Research scholar at Andhra University. I am from Life Sciences. And I have chosen epidemiology of cancer as my research. I'm basically a lecturer in a +1, +2 college. So coming to the next topic, I feel obesity and cancer are the two important significant public health concerns in the 21st century. As I have met around 6,000 patients for my analysis, I couldn't take this concept of obesity because the patients whom I'm meeting, it's like after their treatment or in the process of treatment. And they are also not able to say whether they were obese or because of reasons, because many of them were illiterate. So one of the concepts that I missed was the interlinking between obesity and cancer. Therefore, I went to select my paper presentation. The relationship between the obesity and exercise and cancer risk are complex and multifaceted. Obesity has been consistently shown to increase the risk of several types of cancers, particularly breast, colon, and kidney and pancreatic cancers. Then the objectives in the scope of this presentation is that to examine the epidemiological evidences in relationship between obesity and cancer risk and to investigate the impact of exercise on cancer risk in the obese individual. And also to discuss about the complex interactions between the obesity, exercise, and cancer risk. And as we all know that nowadays the people have become very conscious about being obese. They have taken up regular exercise. So what happens because of this regular exercise? There can be chances that the person can avoid getting cancer. This is also one of the aspects which we can pay attention to reduce the cancer data or upcoming cancer analysis in the world today. Then what happens? Why this potential mechanisms? Several mechanisms underline the relationship between the obesity and the cancer. First one is insulin resistance. Obesity is often accompanied by insulin resistance, a condition where the body cells become less responsive to insulin. So therefore, what happens? That leads to accumulation of the fat and also the inflammation. Obesity is characterized by chronic inflammation, which can lead to the production of pro-inflammatory cytokines and the activation of pro-inflammatory signaling pathways. So these pathways can promote tumor growth and also metastasis. And because of obesity, that can also lead to hormonal changes, which help, because of which there will be increase in the levels of estrogen and testosterone, and thus that will be led to these can promote growth of hormone-sensitive cancers, such as breast cancer, etc. Types of cancers associated with obesity are breast cancer, colon cancer, kidney cancer, and also pancreatic cancer. As we know that there is insulin resistance and there is also breast cancer. Breast cancer is mostly because of there are changes in the hormones. Then what happens? The impact of exercise on the cancer risk in obese individual. Exercise can be shown to reduce the risk of cancer in the obese individual. But the epidemiological evidences and potential mechanisms underlying this relationship are not fully understood. There is not so much research done on this. It is lately the people are beginning to take up and pay attention to this obesity. The epidemiological evidences, numerous epidemiological studies have investigated between exercise and the cancer risk in obese individuals. That is, around 22 studies found that high levels of physical activities are associated with a reduced risk of colon, breast, and endometrial cancers in the obese individual. And the obesity basically leads to even to the cancers of the uterus or what is it called, PCODs. All these are the one of the reasons for outcomes of the obesity which affect human being. And then several potential mechanisms may underline the relationship between the exercise. That is, improvement if we do exercise, how we can reduce obesity and also further occurring of cancer. What happens when we take, which can reduce the risk of cancer. And there is also reduction in inflammation. Exercise has got anti-inflammation, can reduce the risk of cancer. And changes in the hormonal levels, exercise can affect the hormonal levels, including the reductions in estrogen, testosterone, which can reduce the risk of hormone-sensitive cancers. Then types of exercises. What are the types of exercises can be taken is, one is aerobic exercises, which includes brisk walking, cycling, swimming. And then resistance training is that weightlifting, body weight exercises, etc., which will show to improve insulin sensitivity and reduce inflammation. Next, we have got high sensitive interval training. That is, this is mostly done in the gym, where that improves insulin sensitivity and reduces inflammation, which can reduce the risk of cancer. Then implications for clinical practice, assessment of obesity and physical activity. The healthcare provider should assess patients' obesity status and physical activity levels to identify those who are at risk of cancer. And personalized care, prevention, and treatment. Healthcare providers can use information on patients' obesity status and physical activity levels to develop personalized cancer prevention and treatment plans. So one of faculty in the college was affected with cancer, and then the doctors have prescribed for her weight reduction methods along with the chemo and radiations. So after the person has completely reduced and she has reduced a lot of weight, after that the reports say that she has been really cured of cancer and now she is safe. So after the treatment plus as well as paying attention to this obesity. Incorporating exercise into the cancer treatment. Exercise can be incorporated into the cancer treatment plans to improve treatment outcomes and also reduce cancer-related symptoms. Then implications involved in the public health policy, promoting health, weight, and physical activity, increasing access to exercise and physical activity programs, and supporting research on obesity, exercise, and cancer risk. So we have been paying attention so much about tobacco, alcohol, gutka, and many other aspects like eating most of the time non-veg. So the kind of aspects. Now, slowly, maybe the focus should be moved towards the relationship between obesity, exercise, and the cancer. In conclusion, I have done this as a literature review. So obesity is a significant risk factor of cancer. Obesity has been consistently shown to increase the risk of several types of cancers, including breast, colon, and pancreatic cancers. Exercise can reduce the cancer risk. That's what we have been talking about. And then we have got the interplay between the obesity, exercise, and cancer risk are complex. So considering the interplay between the obesity, exercise, and cancer risk is crucial for cancer prevention and treatment efforts. And healthcare providers and public health policymakers, we need to take the complex relationship between these factors when the developing cancer preventions and treatments that are there here. And further recommendation is trials. which we can do, healthcare interventions. Then in conclusion, the interplay between obesity, exercise, and cancer risk is critical area of research that has been significant implications for cancer prevention and treatment. Further research is needed to fully understand these mechanisms. So if we do case control study, then we will be able to really understand the interplay between the cancer, obesity, and the exercise. So these are the references that I've used. Thank you so much. I am done with my presentation.
Entitled with Autophagy-lysosomal interplay in the survival of dormant type doxorubicin and paclitaxeltolerant persister cells in triple-negative breast cancer. The term cancer came from an ancient Greek word kartinos, that means crab, because it's like a crab. When it holds or when it grab on, it don't let go, and it is the second leading cause of death. If we see the current scenario based on the WHO report, if we see the incidence considering the both sexes, breast cancer, the occurrence of breast cancer is the come foremost, and if we consider only the females, the incidence is highest of breast cancer. And if we consider the mortality, breast cancer comes to the second leading cause. And if we consider the mortality among female, based on the WHO report 2022, it comes the leading cause. The global breast cancer statistics says that if we consider the incidence and mortality in female, the Asian countries hold the supreme position. Among other subtype of breast cancer, the most aggressive one is the TNBC, because it lacks estrogen receptor, progesterone receptor, and HER2 receptor. The key statistic says that 10 to 20% of all breast cancers are TNBC, and it contains high-graded tumor, and it frequently metastasizes to brain and lungs. And why it is more aggressive? Because it shows high proliferation and rapid growth, and it has limited treatment option, and it shows high recurrence rate. So it cannot be treated with hormonal therapy and HER2 targeted therapy. So the major problem of cancer is not that cancer happens. Another major problem is second time it recurred after treatment also. So the question is of my research topic is, why does cancer recur, breast cancer recur? So when we usually treat with chemotherapeutic high doses of chemotherapeutic drug, then few cells remain there in the body, which further regrow even after withdrawal of the chemotherapeutic agent. Here is the cause of the reoccurrence of cancer is the drug tolerant persister cells presence. The characteristics of the DTP or drug tolerant persister cell are like the cell cycle arrested in this phase, and the cells of this phase shows like dormant, and several non-oncogenic pathways are activated during this phase, and these cells shows stem cell like marker like LDH, CD133, CD44, etc. So when I started my journey, some papers are also enlisted about the DTP cells. Like these DTP cells are more dependent on GPX4 inhibition, although it is varied to different cancer. And few papers like claim that it is related to mTOR inhibition. mTOR inhibition or some sort of like autophagy or lysosome mTOR, this type of pathways are also related to this phase. So that's why we thought that autophagy might be linked to this phase. Although that time there was not such paper, even now also there is not such claim is there. But I was interested specifically on autophagy because this shows like dual mechanism in our body. Like it sometimes it shows like survival mechanism and sometimes it shows like a cell death mechanism. So it's like working on autophagy was little bit tricky. So the snapshot of my work is here. So the title of my work is in exploring the role of autophagy and lysosomal protein in the survival of drug-tolerant persister cell in TNBC. So the aim of the project was to explore the possible mechanism for survival of DTP to improve the relapse rate of TNBC. To achieve the goal of my project, we first established the cellular model of DTP through MTT and cell culture. Further, we characterized the DTP through immunofluorescence, MTT, scratch assay, and different other mechanistic assay. After that, we tried to see that how autophagy and lysosomal content is related to this phase, and lastly we tried to see that how these two mechanisms or these two related things are helping in survival of the DTP. To achieve that we did MTT and several knockdown and flow cytometric assays we have done. To generate the DTP, first we have given high doses of chemotherapeutic drugs like doxorubicin and paclitaxel in proliferating control cell, and after some days we collected the DTP cells for our further work. And here the control cell we have used two TNBC cell line, HS5780 and MDMB231. Then we characterize the DTP. So when the DTP generated in our model, only 5 to 10% cells were remaining, and we evaluated by MTT assay. Further, we did beta galactosidase assay, which is actually a marker for dormant or quiescent like phase, and we have seen that when we have done this assay, dark blue staining was there. That means the cells are non-proliferative and dormant in nature. After that, we did scratch assay, and we saw that the cells are mostly non-migratory in nature. A little bit migratory in nature compared to the proliferating control. That means again it proved that it is not it stays in the dormant state. And from the microscopy itself, we have seen that the cells are like larger in structure. So to visualize that, we did phalloiding staining to see the whole cell, and from here we have seen that the cells are very large in structure. Again, we try to see that if the cells are stays in the dormant state or not by different molecular marker detection. To achieve that, we did Western blot of CDK4 and P21, which are related to cell cycle pathway, and also the CDK4 specifically it is related to the proliferating marker. So we have seen that in both cases, HS5780 and MDMB231, doxorubicin treated and paclitaxel treated, the CDK4 expression was consistently low. That means the cells are not proliferating in nature. Again, the senescence marker P21 that was upregulating. That again hinted that the cells are non-proliferative nature and stays in the dormant state. But the important feature of this state or of these cells are these cells shows stemness as well. For this, we checked the CD133 was up in mRNA level, and we have seen that this was highly upregulated in both the cases of MDMB231 and HS5780 with doxorubicin and paclitaxel treatment. After that, we found the spheroid in our lab, and we have seen that normally after giving that much of higher dose, the organoid or the spheroid should be broken. But after 12 days of treatment also, the shape was little bit intact, although it was distorted, but little bit also intactness was there inside. And in spheroid model also, when we checked the P21 level, the P21 was consistently high in MDMB231, doxorubicin and paclitaxel treated DTP. And we have concluded from this data that when a proliferating control cell was there and we used to give chemotherapeutics in a high exposure, the cells number will be less and it will come to the static position. And we have done some other experiment also. From that, we have seen that if we keep the DTP cell for prolonged time, like after even 40 to 50 days, the cell again started regrown. That means the DTP cells are the responsible things which are responsible for resistance. And as I was interested in autophagy pathway, we checked the different autophagy protein in DTP, and for that we did actinium iron staining. From actinium iron staining, we have seen that high fluorescence of autophagic vacuoles. This red marks are showing here in both the cases, MTMB 231 and HS5780. And further, we did RT-PCR analysis of different autophagy related genes, and in most of the cases we have seen that it's in a significant level the autophagy related genes are upregulating. Finally, we did western blot of the key marker of autophagy, that is LC3B. LC3B2 was increasing in every cases. And then we have done immunofluorescence, and we have seen that in both cases, doxorubicin and paclitaxel treated MDMB, autophagy or the LC3 puncta are very much intense. And in in spheroid model also, the LC3B2 was consistently high in both the cases of MDMB, doxorubicin treated and paclitaxel treatment condition. And from this data, we have concluded that in DTP, the autophagy induction is high, and LC3B is also high. Further, as lysosome is too much related organelle to autophagy pathway, we checked some lysosomal protein also. As LAMP1 and LAMP2 are the most key protein of lysosome membrane formation. We checked these two protein expression, and we have seen that in every cases the LAMP1 and LAMP2 expression was high. And further, in spheroid model, LAMP1 and LAMP2 was also high in consistent level. And in artificial level also, LAMP1 and LAMP2 expression was high. Further, we did immunofluorescence of the two protein, and this is in HS5780, doxorubicin treated and paclitaxel treated. Here is also from there also we can see that it is in a significant level. The fluorescence is high, and in MDMB, both doxorubicin treated and paclitaxel treated condition, the LAMP1 and LAMP2 expression is becoming high. Further, we have done lysotracker staining experiment. From there also we have seen that it is consistently high in DTP condition. And from there we have concluded that in DTP, the LAMP1 and LAMP2 expression is high, and the lysosomal number is also high. Further, we wanted to see what will happen if we inhibit the autophagy pathway or induce the autophagy pathway. For that, we have used hydroxychloroquine, which is a known marker for autophagy, or known inhibitor of autophagy, and a known inducer of autophagy is rapamycin. And when we have used the rapamycin after formation of DTP, we have seen that MDMB treated doxorubicin condition and MDMB treated in MDMB paclitaxel treatment, and in the same condition of HS5780, we have seen that consistently the number of the cell is becoming high. And when we have treated with hydroxychloroquine, the cell number is becoming low. And here we have done the bright field imaging. From this also, we have seen that hydroxychloroquine treatment condition, the number of the dead cell is becoming high. And then we have done annexin PI staining in flow cytometry. From there also, we have seen that when we have used doxorubicin treated DTP condition, when we treated rapamycin, the live cells are the number of the live cells is becoming high. And hydroxychloroquine treatment condition, the cells are dying, and the early apoptotic cells are also here. The percentage of early apoptotic cells are here. The number of the early apoptotic cells are becoming high in case of hydroxychloroquine treatment condition. Same type of data or same type of experiment we have done with the paclitaxel treatment condition. There also we have seen that the annexin PI staining assay. From there also we have seen that hydroxychloroquine treatment condition, the cells are dying. Further, another agent, paclitaxel, which is also a lysosome disruptor as well as a autophagy inhibitor. And another agent we have used, which is a lysoosmotropic agent, LLOME, when we have treated in both the condition, paclitaxel and doxorubicin treated DTP. In all cases, the cells are DTP cells are dying. Interestingly, when we have done the mitosox staining assay in flow cytometry, we have seen that after giving bufalomycin and LLOME, the cells or the mitochondrial ROS production is becoming high. And same data we have found in doxorubicin treated condition also. So that was from there that we have concluded that in DTP condition, the lysosomes are actually helping to reduce the mitochondrial ROS productions and making the cell viable. And for further affirmation, we have done the knockdown assay of LAMP1. We have chosen LAMP1 because LAMP1 and LAMP2 actually the most prevalent or highest number. It shows the highest expression in lysosomal membrane. And we have seen or we read some paper that time that LAMP1 actually, if we knock down or if we knock out the LAMP2, the mice mod in mice, the mice will not be viable. So that's why for feasibility we have knocked down the LAMP1. And first confirmation was done that LAMP1 knockdown happened or not. We checked from Western blot, and we have seen from here that almost 90% protein was less. And from with the knockdown chain, we have tried to make DTP with both doxorubicin and paclitaxel. And we have seen that after 6-day treatment, or also 6-day treatment only, compared to the scramble control, which is treated by which is formed by PLK01 plasmid and shRNA treated or the knockdown cell, the cells are dying more. Even after 12th day, like very few cells were there compared to the scramble control, which is PLK01 treated. And from this, we have concluded that LAMP1 knockdown actually inhibits the DTP formation. And for further affirmation, we have done MTT assay or the cell survivability assay in knockdown cell and scramble control cell. And in both the cases, in paclitaxel and doxorubicin treated condition, the knockdown cells are actually showing high death toward doxorubicin and paclitaxel. That means the cells are more susceptible toward doxorubicin and paclitaxel. And again, we have done the mitosox assay through flow cytometry. From there also, we have seen that after formation of DTP in shRNA DTP condition, the cells are most rightward shifting. That means if we knock down the LAMP1, the cell will shows more mitochondrial ROS production. From there, we have concluded that if we treat bufalomycin or LLOME, or if we knock down the LAMP, the DTP will not be viable. So the summary of my work is here, that this is the autophagy canonical pathway, which start from the phagophore formation. After phagophore formation, autophagosome formation will be there, and after autophagosome formation, it will be conjugated with the autolysosome formation, and finally it will help in cell survival. So if we induce this process through rapamycin, the cell will be survival. The survivability will be enhanced. And there is another part, that is lysosome, which will help in autophagy process, where the LAMP1 and LAMP2 shows to be high in DTP condition. So that is actually, if high, then autophagy will be higher, and this is actually helping in mitochondrial ROS production or ROS regulation. And if we inhibit this process through bufalomycin or LLOME or hydroxychloroquine, the total process will be hampered, and that time the cell will not be viable. So Finally, I want to acknowledge my research team. Specifically, I want to acknowledge my guide for supporting me always. And if there is any question or suggestion, I will be happy to accept.
Present a research project from my lab that's focusing on the role of epigenetics in treatment response in a pediatric brain tumor called medulloblastoma. This is the outline of my talk. I first am going to give you a short introduction into the world of epigenetics and how it regulates DNA damage response. Then I'm going to talk specifically about the epigenetic mark H3 lysin 27 trimethylation and how it regulates radiation response in medulloblastoma. I will present some of our findings on a mechanism of radiation resistance driven by the loss of the system mark in medulla. And then finally, I'm going to talk about some strategies how to overcome this radiation resistance in a selected group of patients. So when we treat cancer, the three main sort of modalities that we use is obviously surgery, radiation, chemotherapy. Now, chemotherapy has been complemented by immunotherapy, but we can summarize it as a systemic treatment. And apart from surgery, radiation and classic chemotherapy typically kill cancer cells by damaging their DNA. And they do so by inducing specific DNA lesions. For example, radiation induces single-strand breaks, double-strand breaks, as well as oxidative damage. And these lesions are then recognized by specific protein machineries that can signal those particular DNA damage lesions and activate certain pathways to repair those. And therefore, knowing those pathways, we can target those signaling pathways in order to improve the tumor response through a genotoxic treatment. Now, how does epigenetics revolve around DNA damage response? So first of all, what is epigenetics? Epigenetics describes any kind of changes to chromatin, which is the DNA protein complex consisting of DNA and histone proteins that can be structural or chemical change. And it can be local, meaning occurring in the area of DNA lesion, or global and affect the entire epigenome. And it can be triggered by DNA damage induction or can occur at baseline and then affect DNA damage response. So histone proteins shown here, like for example, H3 and H4, H2, H2B, have N and C terminal tails that can be chemically modified through post-translational modifications that can change the epigenetic code. And in the DNA damage response, some local changes that occur specifically at the site of DNA break can, in fact, be very important for induction of signaling cascades in DNA repair, and this can be methylation, acetylation, ubiquitination events. Interestingly, also global epigenetic events that occur at baseline, for example, as a result of cancer metabolism, in this case, the H3K9 trimethylation, that can be raised in certain cancers due to metabolic changes. They can then affect subsequent DNA damage response upon DNA damage induction. So in this case, for example, high baseline level of H3K9 trimethylation prevent further increase of H3K9 trimethylation at the site of DNA break, which then can disturb the recognition and the signaling of the double-strand break by the tumor cell, which then can result in sensitivity to double-strand breaks. Now, we specifically focused on the epigenetic mark H3K27 trimethylation in medulloblastoma. So first of all, let me explain what a medulloblastoma is. It's a relatively rare tumor. However, it's the most common primary malignant brain tumor of the childhood. It originates in the posterior fossa, basically in the area of the cerebellum, and its danger is that it can form leptomeningeal disease, metastatic disease to the spine, which is then much harder to treat. Medulloblastoma was first described pretty much 100 years ago in the mid-1920s. And radiation was introduced into treatment of medulloblastoma quite early on, basically in the mid-20th century. Chemo was introduced in the 1970s. And then over the past about 20 years, we've had an explosion of molecular data describing the biology of medulloblastoma. And four general molecular subgroups of medulloblastoma have been described, including Wnt sonic hedgehog group 3 and group 4, with group 3 having the worst prognosis of them all. Now, interestingly, group 3 and group 4 can also partially overlap, so it really makes most sense to summarize medulloblastoma as Wnt sonic hedgehog and then non-Wnt non-sonic hedgehog consisting of group 3 and 4, which then contain up to 8 different subgroups. Typically, medulloblastoma is initially treated with surgery. It's an emergency that needs to be treated right away, typically due to the symptoms that the tumor causes because of its mass effect. And then the surgery is followed by radiation and chemotherapy. When we treat those children with radiation, they initially are treated to the entire brain and the spine, again, trying to eradicate any kind of micrometastatic disease or even macrometastatic if the mets are already present. And this is followed by the boost to the tumor bed. And the question is, given all the information about the molecular aspects of the biology of the tumor, do we use any of that knowledge to predict treatment responses? Does it affect treatment decisions? And do we have any new treatments that arose again based on that information? And the answer is unfortunately no, at least not in the routine clinical practice, apart from several clinical trials where this is being tried to be implemented. All patients are pretty much treated the same. And one of the main issues of medulloblastoma is radiation resistance, which then results in tumor relapse. And typically, those patients who suffer a relapse, unfortunately, succumb to that tumor. And the way we typically stratify patients is just based on clinical aspects, and we stratify into standard and high risk. Standard risk is no macrometastatic disease on imaging, almost a complete resection, and the patients have to be over 3 years old. They typically treated with a bit of a low dose of radiation to the craniospinal axis, whereas high risk, which basically is everybody else, is treated to a higher dose of 36 gray to the craniospinal axis. But again, we don't use the molecular information for this. And so far, we have to admit that despite all the molecular profiling that's been done and epigenetic profiling, we still don't know any or much about the mechanisms of treatment and resistance, and also there are no markers that can predict radiation and chemotherapy response. Based on a work by Richard Gilbertson back at St. Jude, who has analyzed several molecular aspects of different types of medulloblastoma, we decided to look at the histomarker H3K27 trimethylation and its role in treatment response. And the reason for that was because they've observed that specifically in group 3 and 4, there's a substantial number of patients who have with tumors who have really high levels of the system mark, but some lack it. So there was quite a variability, as you can see here. So there is like really high expression or low expression, whereas Wnt and sonic hedgehog typically have low expression of the system mark. And we wondered whether this, or like the expression levels of H3K27 trimethylation in any way correlates with the outcomes of medulloblastoma. The H3K27 trimethylation histomarker is induced by the histomethyltransferase EZH2. What we did, we analyzed a panel of tumor samples, staining them for H3K27 trimethylation, and then we correlated the expression of the system mark with survival. So here are some samples of the negatively stained tumors and positively stained tumors, and total H3 was used as a control. And we observed that in roughly half of group 3 and group 4 medulloblastoma tumors, the system mark was lost. And then when we looked at survival and progression-free survival, we saw a remarkable difference between H3K27 trimethylation positive and negative tumors. So the positive tumors, here shown in red, do relatively well. They have a low rate of relapses, and also overall survival is really good. On the other hand, H3K27 trimethylation negative patients did significantly worse, with significantly higher rates of relapse, and also overall survival was worse than in the trimethylation positive patients. So we then wondered what the molecular mechanism is behind that. To do so, we adopted a group 3 medulloblastoma model that was initially developed at St. Jude and Martin Russell's lab. And basically, it uses 53 negative CDK and 2C negative MUC expressing murine granule neuron precursor cells that basically can be then implanted into cerebella, and they form tumors that, based on transcriptional and epigenetic profiling, very much mimic the human group 3 medulloblastomas. And these tumors can be also taken out, and they basically can be chopped up, and the cells can be then cultivated ex vivo, and they can be used basically as an in vitro model, or they can also be genetically modified and then reimplanted into brains and used as an in vivo model as well. And so by knocking out EZH2, we were able to basically develop isogenic cell lines, like 2 isogenic cell lines that, again, group 3 medulloblastoma cells. They differ only in the EZH2 status and therefore in the H3K27 trimethylation. So we have positive and negative cells. And when we expose the cells to radiation, we observe something very similar to what we saw in the clinic, namely trimethylation positive cells respond, here shown in blue, respond much better to radiation, whereas trimethylation negative cells, here shown in red, are relatively resistant, which again seems to correlate with poor outcomes in the trimethylation deficient patients. We then wanted to know what lies behind this phenomenon and why are they resistant to radiation when they lose this particular mark. And so first we looked at the kinetics of DNA repair. And in fact, DNA repair was pretty much similar between the trimethylation positive negative patient cells. We also looked at the cell cycle distribution, and that didn't really change either. We looked also at the induction of apoptosis and autophagy and a couple of other cell death pathways, and in fact, there was not much of a difference either following radiation exposure. So finally, we focused on pro-survival signaling pathway, including the ACT and the MAPK signaling pathways. And what we saw was that both pathways are in fact activated following radiation exposure in our cell lines. Interestingly, whereas the MAPK signaling pathway here expressed by phosphor-ERK was activated very similarly in the trimethylation proficient and deficient cells, we observed that activation of the ACT signaling pathway here expressed by ACT phosphorylation was much earlier and much more excessively activated in the trimethylation deficient cells. And by inhibiting ACT signaling pathway, either by inhibiting ACT directly with a small molecule inhibitor of ACT or PI3K inhibitors, and PI3K basically sits upstream of ACT in the signaling pathway, we in fact were able to sensitize the EZH2 knockout H3K27 trimethylation deficient cells to radiation and basically restore radiation response to the levels of the trimethylation normal cells, so EZH2 wild type cells, and suggesting that in fact an excessive ACT signaling is responsible for radiation resistance in the trimethylation deficient cells. We then wanted to know, well, why are these trimethylation deficient cells overactivating the ACT signaling pathway? And as we looked more closely into the epigenome of the cells, what we observed was that there was a reciprocal switch. They basically lose the trimethylation and they gain the H3K27 acetylation. So they have a hyperacetylated status. And what we hypothesized was that because the trimethylation is a transcriptionally silencing histone mark, whereas the acetylation activates transcription, we hypothesized that that switch basically changes the balance of the transcriptional silencing and activation, resulting in increased transcription of an ACT pathway stimulator, which then leads to radiation resistance. To first initially verify if that hypothesis is even true, we actually went ahead and suppressed the H3K27 acetylation using an inhibitor of the P300, histone acetyltransferase. And in fact, by doing so, we were able to restore the radiation response in the EZH2 knockout H3K27 trimethylation deficient cells to the level of the EZH2 wild type cells. And interestingly, in the EZH2 wild type cells, the small molecule inhibitor didn't really have an effect, again, because they are primarily responsive to radiation. We then wanted to know which factor is specifically affected by this epigenetic switch that can stimulate then the ACT signaling pathway. And then we looked at, we did a ChIP-seq, and then basically looked at different factors that are known to affect the ACT signaling pathway. And we specifically looked at the genes where you see a clear loss of the H2K27 trimethylation, accompanied by a gain of H2K27 acetylation within the promoter region. And two genes that stood out was EphA2 and PIK3CB that are known to affect the ACT signaling pathway. And we then just did a normal ChIP to confirm the results of ChIP-seq, and we were able to confirm it for EphA2, but actually not for PIK3CB. So we focused on EphA2. It stands for afferent type A receptor 2. It's a tyrosine receptor kinase, and it's been shown before that high expression levels of EphA2 can stimulate ACT signaling. We then did a reverse transcription PCR to show that, in fact, the transcription of the EphA2 gene is increased in the trimethylation deficient cells that also led to increased EphA2 protein levels. And then we went back to our tumor samples and we stained them for EphA2. And in fact, we observed a correlation that in the trimethylation negative cells, there were high levels of EphA2, but low levels in the H2K27 trimethylation positive cells. So suggesting that, again, loss of the H2K27 trimethylation leads to an overexpression of EphA2. Then by using EphA2 inhibitors, so remember it's a tyrosine receptor kinase, so there are some specific kinase inhibitors that can target this protein. By doing so, we were able, again, to decrease the excessive ACT signaling induced by radiation in the trimethylation deficient cells, and also restore the radiation response to the levels of the trimethylation proficient cells. Then we wanted to know what would be a good potentially translational and later on clinical strategy to target radiation resistance in the trimethylation deficient medulloblastoma. And so we used the P300 inhibitors, as you've seen some other inhibitors, but they have a lot of issues with pharmacokinetics, also off-sided or like off-target effects. And one of the inhibitors we then focused on was a BRD4 inhibitor, or BRD4 class, inhibitor class of drugs. Here is an example of JQ1, which is a BRD4 inhibitor, and interesting has been shown, the reason why we chose it to begin with was because it suppresses the H2K27 acetylation by interfering with the activity of P300. And it actually does it at a very in a very efficient way, even better than the direct P300 inhibitor. So here we show that by using JQ1, we can very strongly suppress the excessive H2K27 acetylation in the trimethylation deficient cells. That also drove down the increased EphA2 transcription and radiation-induced excessive phospho-ACT signaling, as we show here. And so we did it in mouse cells as well as in some human medulloblastoma cells, again confirming that this is true for mice and as well as human tumors. And then finally, we put BRD4 inhibitor on our cells, and we show that it's very effectively can restore the radiation response in the radiation-resistant H2K27 trimethylation deficient cells. So based on this data, we proposed the following model where in the H2K27 trimethylation proficient medulloblastoma, you have mainly methylated chromatin, which then prevents an excessive expression of EphA2. ACT is activated by radiation, but ACT is activated at normal levels, and the cells are radiation sensitive. On the other hand, if the cells lose the H2K27 trimethylation, either due to EZH2 mutations or expression of the specific H2K27 specific histone demethylases, that results in low H2K27 trimethylation levels, which then leads to an epigenetic switch where you have an increased acetylation of the cystone mark. That increases the transcription and expression of EphA2, and that leads to an excessive ACT signaling once the cells are exposed to radiation, and that confers radiation resistance to the cells, which can be targeted by BAT inhibitors that can suppress this H2K27 acetylation. So in future, we basically went ahead and started testing different kinds of BRD4 inhibitors, with the fact that JQ1 again doesn't have the best pharmacokinetic properties and also typically can't cross the blood-brain barrier. And we found the agent rituximab to be actually quite effective, even potentially more effective than JQ1, as shown here by the green line, in multiple medulloblastoma cell line models. And so rituximab is also known to have a blood-brain penetrance, and so we're looking forward to take this now into murine models, in vivo models, and test this drug with the radiation in the trimethylation deficient medulloblastoma model, and hopefully be able to translate our results into clinic within the next couple of years. Another interesting perspective that I would like to give is that besides medulloblastoma, there are some other tumors, some pediatric brain tumors that are known to have an H3K27 trimethylation loss. So here we investigated non-Wnt, non-sonic hedgehog medulloblastoma, basically group 3 and 4, showing that due to EZH2 mutations or overexpression of the demethylases, there is a loss of H3K27 trimethylation. That was the whole story I just presented. However, interestingly, in PFA ependymoma, due to overexpression of a protein called EZHIP, which stands basically for EZH2 inhibitory protein, there is also a low level of H3K27 trimethylation. And also in diffuse midline glioma, due to mutations, so-called oncogenic epigenetic mutations of H3 lysine to the methionine, there is a decreased level of H3K27 trimethylation. This tumor is also quite resistant to radiation and to treatment in general. And we are wondering if, in fact, our concept might apply to these tumors, that they developed treatment resistance due to overactive pro-survival ACT signaling, which potentially could be counteracted through BRD4 inhibitors. So that's something that we're interested in testing as well. So finally, I would like to thank the members of my lab, including Nishan, Kumaresh, and now Nito has taken over this project. I would like to thank the Andrew McDonough B+ Foundation and the Truth 365 Collaborative Foundation for funding this project. So thank you so much for your attention, and I'm more than happy to take any questions.
By the GMC in the UK. I'm going to be sharing with you a case report of a rare syndrome called Lemierre syndrome, which is a thrombophlebitis of the internal jugular vein. It can be induced by many things, like repeated upper respiratory tract infections. But in this particularly case, we present a case where it was induced by laryngeal cancer. So I hope you find it interesting. First of all, just a brief introduction and background about Lemierre syndrome. Lemierre syndrome, it's known by many other names, like septic thrombophlebitis of the internal jugular vein. I'm going to be explaining the whole process about how this develops, right? But it's characterized by this association of a thrombus formation, a clot into the internal jugular vein, and most of the times it is caused by a septic emboli that travels from other place to the internal jugular vein, causing this obstruction at the venous level. It's rare, right? It mainly affects young adults, and most of the times, as I was telling you, it's because of repeated upper respiratory tract infections, right? The microorganism, the bacteria that it's responsible most of the times, it's Fusobacterium necrophorum, right? It can be isolated in most of the cases of this rare syndrome, and has the mortality right now. It's not that high because of the function of the antibiotics, right? But it has a high morbidity. If it is not promptly diagnosed, of course, the mortality can be high because it can extend to cause septicemia and other multi-organic failure. The association with malignancy, it's rare, right? That's why we're presenting this case, because it's not something that it's that common. Just to talk about a little bit about the epidemiology about this case, the incidence of this syndrome, it's 14.4 per million per year, and it mainly affects the ages 15 to 24 years, and also 1.4 per million per year in adults more than 40 years old. It has a mortality. As I was telling you, the mortality right now is not that high because of the use of antibiotics. Right now, it's around 4 to 10% of mortality, just in comparison to the pre-antibiotic era where it was more than 90%. But nowadays, because of the increasing and the growth into the antibiotic resistance, this is now just getting a little bit like a problem, right? Right now, there has been an increase into the numbers of cases, and it's supposed by the literature that it's due to antibiotic resistance and also less indication of tonsillectomy. As I was telling you, recurrent episodes of upper respiratory tract infections, such as tonsillitis, can be a risk factor for developing this syndrome, right? So if the tonsillectomies are less indicated, that could mean that you're going to be having more tonsillitis, and that could be a risk factor for developing this syndrome. Okay, so just moving on into the case presentation, we have a patient, a 54-year-old male patient, had an important risk factor of smoking. He was smoking 20-pack year history of cigarettes and also moderate alcohol use. And he presented with a 2-week history of odynophagia, dyspnea, dysphonia, fever, weight loss, and cervical swelling, right? He was addressed and he was assessed by the medical team, and they found an erythematous pharynx, the cervical mass nodular, mobile, and indurated. And on the direct laryngoscopy, they found an ulcerated lesion of the left vocal cord, right, as well as an elevated white cell count. And then they request for blood cultures, in which they isolated Fusobacterium nucleatum, right? So they performed as well some imaging studies, right? They did an ultrasound where they found a nodular lesion into the neck, right? Which was obstructing the left internal jugular vein, right? At this point, we start just thinking about the possibility of Lemierre syndrome, right? Because of the history of smoking, right? The patient was also reporting having recurrent upper respiratory tract infections. And also because of the isolation of the Fusobacterium, it was one of the top possibilities, right? But then we continue just requesting more imaging studies, right? Like a CT scan, where we actually find out that there was a mass compressing the carotid artery, right? But the image was not that clear about if the obstruction was at the level of the artery, of the carotid artery, or it was more into the left internal jugular vein, right? That's why then we requested an MRI where we contrast and enhance MRI, where we confirmed that the obstruction was actually on the internal jugular vein, right? And it was that confirmed the diagnosis of a Lemierre syndrome, right? Of a septic thrombophlebitis. In here, we can see the images. We can see the CT images where we see a level of obstruction. As I was telling you, it was not that clear if the obstruction in the CT was at the level of the artery, right, of the carotid artery, or on the internal jugular vein. We definitely could see that there was a mass, right, a hyperdense mass at the level of the neck, but it was not that clear if it was on the level of the artery or the vein. Right, so that's why we continue just requesting more imaging studies, right, until we got the MRI and we actually confirmed that it was indeed the obstruction was on the level of the left jugular internal jugular vein, right, and it was externally compressing the artery because of the big mass of the obstruction, right. So this imaging evidence with the isolation of the Fusobacterium in the blood cultures was a confirmatory diagnosis of Lemierre syndrome, right? But now the important thing was to determine what caused the Lemierre syndrome, right? So I was telling you, in most of the cases in literature, it's reported that Lemierre syndrome it's caused by repeated upper respiratory tract infections or pneumonia or liver abscesses, where they send septic emboli to the internal jugular vein and they cause this septic thrombophlebitis, right? But this was not the case, because it was something more. The patient also was presented with weight loss, dysphagia, right? And had an important risk factor of smoking. So we have to investigate more about the cause. They perform a biopsy of the neck mass, right? And they determined by pathology that it was an invasive squamous cell carcinoma of the larynx, right? And they also found that within the tissue, within the biopsy, there was a colonization of the Fusobacterium nucleatum, right? So that was big evidence to determine that the cause or the causing factor of the Lemierre syndrome was actually the tumor, right? The cancer of the larynx, right? Which is pretty rare. So then, just to continue and give just the whole diagnosis, it was determined that it was Lemierre syndrome, right? But it was secondary not to throat infections or repeated upper respiratory tract infections, but more secondary to laryngeal carcinoma, right? Okay, so just to give you an insight of the management and outcome of the patient, of course, we start with antibiotic therapy, right? Just to treat the active infection that the patient was having. We're going to be talking about the kind of treatment of antibiotics that it's supposed to be given, right? But we start just giving ceftriaxone and metronidazole, and then just de-escalate the therapy just depending on the sensitivity results of the Fusobacterium nucleatum, right? But it was a 4-week course of antibiotics to treat the infection over there. Also, because of the thrombus of the internal jugular vein, the patient was given anticoagulation with low molecular weight heparin, right? Most of the times, it's not necessary to give like an invasive treatment, a surgical treatment to destroy or to get rid of the clot into the left internal jugular vein. Most of the times, it's just giving anticoagulation at a therapeutical doses, right? And that was given. Also, the patient had a prolonged intubation, so he was required to perform a tracheostomy, right? And because of the cause of the Lemierre syndrome, the patient, because of the cause being cancer, the patient was just referred to the oncological team, where he was given the chemotherapy and radiotherapy, and the patient was responding pretty well to the oncological treatment to treat the laryngeal cancer. Just talking about the patient outcome in regards to the infection of the Lemierre syndrome, just 48 hours after giving the antibiotic therapy, the patient was responding well. There was a resolution of the fever, the neck pain improved, right? And the patient was discharged on the anticoagulants and also on the blood thinners and the antibiotic therapy, right? And is currently on follow-up with the oncology team to just treat the laryngeal cancer, but it's responding pretty well. Okay, this case highlights the importance of early detection and also a multidisciplinary approach of this kind of diseases, right? Most of the times, as I was telling you, Lemierre syndrome, it's a rare condition, so it's not going to be the first diagnosis that we're going to be thinking about, right? But when we found certain things like the isolated Fusobacterium, like the risk factor of repeated upper respiratory tract infections, and more the suspicion of having a malignant process like a laryngeal cancer, should make us think about these kind of rare conditions, right? In our case, it was something we found out when we have the imaging, right, of the CT scan and the MRI. But definitely something to be aware, and also the fact that it's not all the times related to upper respiratory tract infections. It can also be related to other processes, such as a malignant process, a cancer process, that contributes to the formation and the colonization of bacteria into that, and I'm going to be explaining that in a moment. Okay, so just the discussion points about this case. The Lemierre syndrome, it's a rare condition that most of the times it's triggered by a spread of bacteria. It can be a hematogenous spread or lymphatic spread, or even contiguous spread by being so close to the active source of infection. But it can also be triggered or caused by malignancy, right? Also, whenever someone is having a malignant process, whenever someone is having a cancer process, there are certain risk factors or certain contributors that are going to be increasing the risk of having Lemierre syndrome, right? Because having a cancer will contribute to having a local invasion, hypercoagulable state, and infection susceptibility, because the immune system is not going to be responding that well compared to a healthy person, right? So it's important the importance of this case is, of course, to improve the diagnosis, right? An early detection, the timely use of antibiotics and specific antibiotics once you have the bacteria isolated that it's causing the infection. As I was telling you, in Lemierre syndrome, most of the times it's Fusobacterium nucleatum, and the importance of giving a patient-centered multidisciplinary team care, right? Because that's important to just like give the whole panorama to the patient and really address all the symptoms and all kind of the needs of the patient, right? Like in this case, it was not something just about infectious disease, right? It was also something about oncology. So just giving a multidisciplinary treatment should be the way of doing it. Okay, so just to give you a literature context about this case, there has been an increased number of reports of Lemierre syndrome in recent years. Most of the hypotheses about this reason about the increasing number of cases could be because of the inappropriate antibiotic use, right? Which is just contributing to the antibiotic resistance, right? And also the less indications of tonsillectomies, okay? The recommended therapy for Lemierre syndrome, most of the times, it's using a beta-lactam plus metronidazole in a course of 2 to 6 weeks, right? If there's a high rate of resistance, it could be considered to use piperacillin and tazobactam or carbapenems, right? But that depends on local guidelines and that. Okay, so in here there's a little diagram to show kind of the evidence or to show the contribution and the association between the cancer as a contributing factor to developing the Lemierre syndrome. In this case, we have a patient with laryngeal cancer. In here, the brown mass, it's just supposed to be the cancer, right? It was confirmed to be cancer. And in literature, how they say this cancer develops or contributes to Lemierre syndrome, it's because it gradually creates an ulceration, right? An ulcer that will create bacterial colonization, right? We can have Fusobacterium in the microbiota and the bacteria of the mouth, right? Which can directly travel from the mouth to the larynx, and then by proximity to the neck vessels, like the carotid arteries and the internal jugular veins, these bacteria can travel contiguously by proximity and start just creating a clot and a thrombus formation, right? Because it activates chronic inflammation, coagulating factors, and it ends up just generating an obstruction, like in this case in Lemierre syndrome, causing an obstruction at the septic thrombophlebitis, actually in the internal jugular vein, right? So that's why that's kind of the hypothesis, and that's kind of the pathophysiological route of this case. Just to conclude about this whole case report, Of course, Lemierre syndrome, it's a rare condition. It's not going to be one of our first diagnoses, right? But if we have a persistent neck infection and we have all these kind of features that I was just telling you, we should be considering, right? Because it has a high morbidity, and the mortality is right now is not that high, but yeah, of course, it has a high morbidity. Smoking in this case was a big risk factor because of the developing of laryngeal carcinoma, right? An early and multidisciplinary intervention, it's crucial for saving lives, involving, of course, the ENT department, the infectious disease department, the oncology and radiology to make the correct diagnosis. Okay, so this was a case report published by Curious, and it's currently into PubMed. I don't know if you have any questions or any comments regarding the case report. I will be happy to hear you.